Okay, so we're starting Learning Plan 6, Manage Care for Patients Experiencing Disorders of Childhood. And we start with Chapter 11, Childhood and Neurodevelopmental Disorders. So as an introduction, about 20% of the children and adolescents in the United States suffer from a major mental illness that causes significant impairment. I think that number is absolutely huge, 20%. That is a lot of kids that we're talking about and adolescents. And if we don't really help those kids and adolescents to cope, to feel better, to learn better adaptive coping mechanisms, we really are going to have some adults that are not going to be able to cope and function effectively in their adult lives. So it really is important that we focus a lot on these kids and adolescents. So 20% to me is a pretty alarming number. So when we think about mental illness in children, it's really a disruption to their normal pattern of childhood development. We do have a lot of barriers to assessing, diagnosing, and treating younger people, and those are outlined in your book actually really quite well. So they do talk about how sometimes barriers are just that we simply don't have enough practitioners. There aren't a lot of child psychiatrists. We just lost one in the Sheboygan area who retired. There right now is nobody to replace him, and I know they are working on it, and the adolescent unit at Sheboygan Memorial is actually closed right now. And if there are adolescents that need admission, then they would need to go to another city. So we're talking Milwaukee, perhaps Green Bay, another larger nearby city. So that really makes it very difficult and even more disruptive for the family not having services close by. There might be long waiting lists to get in to get help. So we really do have a lot of different types of barriers. It is also just really difficult to assess a child depending on their age. If they don't have the language skills and the ability to communicate effectively, to think in a more abstract way, if they're very concrete thinkers, if they're still at that developmental stage, are a little bit harder to assess, kind of harder to figure out. And of course, certainly a child, we're thinking maybe even like younger than 3, very difficult to assess. Also, children and adolescents in general are just going through so many different changes in their brains, and so many different changes both emotionally and physically. So sometimes it can be really difficult to figure out what is normal behavior for a child or an adolescent versus what is pathology. Because there are times when, especially think about when teenagers first start, like their hormones are changing and they're growing rapidly, and they're, just undergoing so many different changes all at once. Sometimes how difficult that is for kids, and that they sometimes look emotionally very labile. Their moods are fluctuating. They may be happy one minute, really angry or sad the next. And so, how do you figure out if that's actually pathology, that they're developing an illness? Or is that just normal adolescent behavior? So to me, that's part of the barrier, because it really makes it very, very difficult to kind of figure it out. And again, with mental illness in general, there is no blood test. It's not like you can just go get your blood drawn, figure out what it is, and know how to treat it. So in general, that just makes mental illnesses a little bit trickier to diagnose. We do have a lack of services, and sometimes there's just premature termination of treatment. So treatment stops too soon. Child really isn't better yet, could benefit from longer treatment, but we all know that the insurance companies kind of dictate sometimes the length of treatment that they're willing to pay for, and it may be that child really needed more treatment, longer treatment, in order to really be able to function more effectively. So mental illness in childhood and adolescence really is a family crisis for the most part. And it really does make it difficult for that child to develop academically. Many times it disrupts their flow of pattern with school. And if they're not going to be able to do school effectively, has huge implications for their career and for later on in life. How do they work? How do they support themselves? Social, psychological functioning. So we really need to look at not only the patient also, but the entire family and how they're functioning. So causative factors. Of course, we do have that genetic predisposition. Just because a child has hereditary factors, that doesn't mean 100% of the time that they are going to develop an illness. But we do have to take that into consideration. So they may be at risk for developing an illness. If they live in a very supportive, health-producing, health-giving, less, no stress, no abuse, and all that type of a wonderful environment, it's very possible that they can end up doing very well. And even if they do develop an illness, easier to manage and just maybe easier to bring it under control than a child who lives in a very disruptive environment. So, and again, that whole neurobiological aspect of the that the child and adolescent has so many changes in their brain occurring over a very short amount of time. Adolescents actually have a lesser degree to make good decisions than they did when they were younger children. The part of the brain that's really controlling their emotions, their behavior, their planning, their executive functions, organization skills and all that really are still not quite mature yet. And so adolescents really can seem all over the place and really be very impulsive in some of their decision making. And then if you think about adding maybe drugs or alcohol to that mix, to that very immature brain that is impulsive, and you really have some potential for issues. And sometimes we have to think about that's maybe why an adolescent is tempted by drugs and alcohol, because they have that kind of impulsivity and that lack of ability to think through their decisions and think about the consequences of their behavior. So they may be more likely to experiment and not think that they're going to have any negative consequences from their behavior. So it is kind of almost a scary time of life, because they're going through so many different changes, and we have hormones that are coming into play, and it can be a really, really difficult time. So we have those psychological factors that everybody deals with. Everybody has a different temperament, and so the person with a laid-back, easygoing temperament, perhaps they have like a good sense of humor, and maybe they're just really naturally a happy person. They're probably going to fare a lot better if they have difficult situations than the person who has maybe a more of a angry or irritable, highly reactive emotionally. They just get emotional right away and they don't kind of think things through first. So if you have that type of a temperament, you may end up not coping overall as effectively, or you just have to learn different coping mechanisms. We all have to learn to deal with our own temperaments. If you're too laid back, that might not be good either. But if you're too highly emotional and reactive, then you may end up being more distressed and actually need some help to kind of work on that. And again, that whole concept of resilience. So the child who's resilient is going to seek out the nurturing that they are missing in their family life. So if they're growing up in a really difficult situation, they get their nurturing perhaps through a teacher, a counselor, a neighbor, somebody who's going to provide that nurturing that maybe their parents aren't providing for them. So that ability to bounce back, make plans for themselves, separate themselves from the emotional chaos of the family, and just being overall, being able to kind of set their own goals and think about their own life separately as not just, part of that chaotic family situation. We have to think about environmental factors that can be really difficult for kids. So witnessing violence, especially kids that are witnessing violence on a daily basis, perhaps the violence is in their own home, or they live in a really difficult neighborhood where they're seeing there's a lot of maybe gangs and drug violence, and perhaps all they have to do is look out their window and see things that that kids shouldn't be seeing. So that whole witnessing and traumatic experiences that children can go through can really have an impact on their mental health. And of course, neglect and abuse. Those situations, kids aren't getting their needs met, or they're actually being actively abused. That is causing trauma, and many of those other household challenges, such as if they're poor, they just don't have the money to have the things that they need to live a comfortable life and have their needs met. Of course, all of those are going to impact their mental health. And of course, bullying, and we literally could talk for hours on bullying. And that is, of course, a very big factor in the way that kids feel about themselves, especially if the bullying is relentless and takes place on social media, which, of course, just amplifies it, because then it's almost like you can never get away from it. And that is very different from bullying years ago, when, if you went to school and you were bullied, well, you went home and you were safe. You were in your own neighborhood, you were in your own home, and the bullies weren't there. But now the bullies can be everywhere because of having social media. So, and of course, that makes kids sometimes suicidal, makes them very depressed, lowers their self-esteem, and already childhood and adolescence is a area where people are really trying to figure out, who are they, and are they okay? Do they fit in or not? And it really can be so devastating. I did read about a child who was only 11 who committed suicide because of bullying. And I'm sure that you're aware of, and you have also read of and heard of different types of situations where even children are committing suicide over bullying. So I think that is something that we as nurses have to really think about as a health problem. It's not just a parent problem. It's not just a family problem or a school problem, up to the teachers and the principal of the school. It's not just their problem. It really is everyone's problem, and it is certainly has become a health problem. So, and we have to then think too about cultural factors, that sometimes if kids come from a different culture and their family is, maybe they're from the old country, wherever that might be, and they go home and they are expected to function as if they were, from the old country themselves, perhaps. They have to really go along with their parents' values and beliefs, and maybe some of those are contrary to what they're hearing in school. And then they go to school and they want to be an American. They want to fit in. They want to be like everyone else. And so that makes it very difficult for them. And that could cause them some stress and some mental illness issues, certainly some anxiety, possibly some depression. And again, that whole issue of self-esteem. They may not feel like they fit anywhere. They don't really fit 100% with their parents and their values, and they don't fit 100% with the American values of the other kids at school. Little case study. So Mimi, 13, is a child with many risk factors for the development of mental illness. She's a child of a single mother who suffers from post-traumatic stress disorder from growing up severely abused herself. This has also made her agoraphobic. Mimi's mother is unemployable because of her emotional instability, and Mimi's mother does love her, but often keeps her out of school to take care of her. Despite all this, she develops normally. You hear the term resilience used. So I just want to make a statement too, that just because she has a single mom certainly is not enough to, be a risk factor. There are many very healthy, happy, single parent, family units, where it could be the mom that's raising the children by themselves, or a single dad raising kids by themselves. So that in and of itself does not mean that a child is going to grow up with difficulties. But this particular mom has some mental illness issues herself, and then she's using the child to take care of her own needs instead of taking care of the child's needs. So that would be, that's kind of what we're thinking about with this child. So but it says, despite this, she's developing normally, so she must be getting her nurturing from somebody else, and she must be able to separate herself from her mom enough and have enough emotional intelligence to be able to figure it out for herself and say, these are my goals, this is what my life is going to be like, and kind of separate herself that way and get that nurturing that that she needs from other people. So another little audience response question. Mimi's mother is not abusive or neglectful, but she does put her at risk for being overly controlling and keeping her a bit too close, largely out of worry or fear. So in other words, then perhaps she's too possessive, too controlling, and she's not really allowing her daughter to develop normally. So which of the following is the most prevalent cause of child abuse? Physical, sexual, verbal, or neglect? I'm hoping you picked neglect. In your book, it talks about 75% of child abuse is actually neglect. So just not taking care of the kids, not meeting their basic needs. Physical abuse is, 17%, and 8% are sexual abuse. And honestly, I don't see any statistics in the reading about verbal abuse, and honestly, I'm not sure if we'd even be able to find appropriate statistics on verbal abuse, because I would be willing to bet, and I've talked to police officers, there really is no particular form for reporting verbal abuse. I know that that's true for adults. I'm not sure if that's true for children too. That's not to say it's not devastating and very detrimental for kids to have verbal abuse like that, but it's just not. Boy, it'd be really tough to really keep track of that. People would have to self-disclose, and who's going to do that? Who's going to verbally abuse their kids? So, and you're not going to end up in the emergency room necessarily because you're being verbally abused, but you might if you're physically abused or sexually abused, or even neglected if your needs aren't met and the child becomes ill. So, those three areas you're likely to see. You're not likely to see somebody come to the emergency room just for verbal abuse. So we have to think about assessment. So we have to look at what is the presenting problem? What is happening with that child? So we have to look at, on page 175, there's a nice table right at the very bottom in green, and it talks about types of assessment data. So like the history of present illness, what's the chief complaint? What is the development of the problem? So what's going on? Have they sought help? Is any results from that? And the effects of the problem on the child's life at home and at school, and the effect of the problem on the whole family. And then they also go through a developmental history, like how, what's the child's whole development is of, their developmental, how they have progressed so far through all those stages. Did they reach their milestones in an appropriate way? How do they play? There's friendship activities, and then we have to look up their psychomotor skills, their language, their cognitive skills, interpersonal, academic, and all that kind of good stuff. So we have to think about different ways that we collect data. We interview, we use screening tools. I believe in second semester that you probably did a Denver developmental assessment, perhaps as part of health promotion. So that would be a good type of screening tool to see if the child is developing normally. So that's good information for their developmental level. And we can always get, there's structured questionnaires sometimes for parents and teachers as far as looking at specific aspects of a child's behavior. And we also have to think about the whole mental status assessment. And it's really similar to what we would look at for an adult. So we're looking at their appearance, their behavior, their thought processes, their thought content, their affect, what their basic mood is like, if they're having any hallucinations, any delusions, their motor activity, all of that type of thing, this exact same things that we look at for adults. So on page 176 in Barcarolas, so again, continuing with thinking about that developmental assessment, there's a nice box that talks about the characteristics of a mentally healthy child or adolescent. So we need to think about some of those things as what we're looking for when we're assessing kids. So trusting people, seeing the world as being safe and supportive, correctly interprets reality, and they have accurate perceptions of the environment. So, sometimes really young children might have like an imaginary friend or something like that. But if somebody is an adolescent, maybe they're 12, 13, 14 years old, and they're talking about an imaginary friend, there might be something, of an issue. So we do have to think about their developmental stage. And so how does that play with that? They behave in a way that's developmentally appropriate and doesn't violate social norms. So they're not, creating havoc. They're not going up to somebody and hitting them. They're not setting fires. They're not doing things that are really inappropriate and dangerous. They have a positive, realistic self-concept and a developing identity. So, kids kind of fluctuate a little bit. Again, they're figuring out who they are, but in general that they feel good about themselves. There are times when kids might compare themselves to others and so-and-so is smarter than I am, they're prettier, they're more athletic, whatever. But as long as they feel in general like they feel like pretty good about themselves and they can see maybe their strengths and their weaknesses. And they cope with anxiety and stress using age-appropriate behavior. So, you know what? A child maybe is upset about their parent leaving them. But if they're 13 and they're crying hysterically because their mom is going shopping for a couple hours and leaving them alone, that would not be very appropriate. But, when you drop off a young child perhaps with a new babysitter or something like that, then maybe the child is going to cry and get really upset. That's probably more developmentally appropriate, than a 13-year-old. They adapt and cope with stress and anxiety. They can learn and master developmental tasks, express itself in spontaneous and creative ways. Kids are creative. They're fun. They make a game out of everything. They're running a lot. They laugh. That should be the work of childhood, should be play. So if they're not being creative and just all that imaginary stuff that kids do, making up games and all that, that could be the sign of a problem. And they develop and maintain satisfying relationships. So it would not be a good thing for a child to have just relationships with adults and not to get along with their peers. So that's something we kind of have to take a look at. So if a child is just relating to adults and they have no friends, they can't play with other kids, they just don't, it doesn't work out, then that would signify a problem. So lots of things to think about when we're assessing those kids. And then we have some interventions. So there's all kinds of behavioral interventions. Many times that those, depends on where they are. If you're thinking about employing some of these tactics at home or at school, might be a little different than if a child is in a treatment facility. But many times that these types of programs are based on rewarding desired behavior and trying to reduce the maladaptive behaviors. So, and many times if they're an inpatient mental health type of unit, they usually use a very structured program, and it's a behavioral program to kind of motivate kids towards better behavior. They may have a point system, and they earn points and they can have certain privileges, things like that. Play therapy really is very helpful for kids to express their feelings through the use of play, because play comes just very naturally to children. Bibliotherapy is a wonderful thing to do. It's using literature to help kids express their feelings and gain insight into their own feelings. So if you have a child who's been through a particular type of stressful situation, there are many children's books where the main character is going through maybe that same situation, and then the child gets the book read to them and they can identify with that main character, and if that main character is coping appropriately, they kind of get that sense of hope that they can also cope appropriately. So it really is a very helpful thing. Expressive arts therapy. So art can be that nonverbal. A child sometimes likes to, maybe they can't verbalize their feelings, but they can draw them, they can play them out. So anything like that that helps a child to experience in some kind of a creative way, especially kids that have been through trauma, then they can, sometimes it's easier for them to draw a picture. Journaling would really work with older children. Sometimes they like to just kind of write out their emotions, and it can just be very helpful. Music therapy. So the healing power of music, of course, is just very, very impactful. And so we can use music therapy for any age, children all the way through, elderly people. And it does help to improve our functioning. It helps our brain. But of course, you'd have to pick out really appropriate music, obviously. And we wouldn't want kids listening to heavy metal. That probably wouldn't be so good. Family intervention. So when a child is having a problem, it is the entire family's issue. The family needs to get involved. The whole family system might need to make some changes. So nurses can help families to develop goals and way to improve their communication and just maybe their day-to-day life, the structure of their family. Some families don't have any structure. The kids just eat whenever and whatever. They do homework. Maybe they do it, maybe they don't. There isn't like set bedtimes, set times to do homework, set meal times. Sometimes just that structure of a family can be very helpful. So a nurse might be instrumental in getting a family to have just a little bit better type of environment so that their kids can function a little bit better. Pharmacology, of course, there are lots of medications that are not even able to be administered to kids under 18. So as nurses, we have to be really careful to make sure that if a medication is ordered for a child to treat their symptoms, that we have to make sure that it is something appropriate for their age, and of course in an appropriate dosage. So, and that can really make it very much easier if the child's symptoms are under control. If it is controlled by medication, just makes it overall easier with the family to be able to cope with their child's illness, and has a greater potential for the child to grow. Disruptive behavior management is something that you might have to do with a child who is very very disruptive, but of course things like a timeout can actually fall under that category, and timeouts can be accomplished at home, at school, in a treatment setting, and that's just basically taking a timeout from the activity. They sit on the periphery of they sit kind of on the edge of whatever is going on, or in a separate room perhaps, until they regain their own self-control. And the goal then is to, after they regain self-control, is maybe to even try to talk to the child about it and see if they can come up with what else could they have done. Could they have tried a different way to cope first, before they became disruptive? So that is kind of a nice way to help the kids. You don't want them to see it as a punishment, but just more of as an opportunity to think about their behavior and to plan on how they could do something differently the next time. Quiet rooms, perhaps on an inpatient unit, there might be a quiet room. And it's really more effective to invite that child or adolescent to just go to the quiet room when they feel the need to do that. So in order to kind of get a hold of themselves. A quiet room type of environment can actually help adults also, as just a way to help you to self-regulate. I'm losing control. I'm going to go to the quiet room, chill out, and think about things and cope, try to cope better, soothe yourself, and then you come back out into the milieu, and then you're able to be in better control of your behavior. Okay, there's quite a few others. I think those two are the things I'd really like to highlight as far as disruptive behavior management. Seclusion and restraint, really we don't want to be doing this to kids. And they talk about how dangerous it can be in your reading. We have to remember that children have, they're smaller, their lungs are smaller. Kids have been actually hurt or even killed sometimes because of asphyxiation during different types of holds for restraints. So it is way better to try not to use any type of restraint or seclusion, like locking a child in a room. We really try to avoid those types of interventions. Advanced practice interventions. So group therapy. Younger kids, again, you can do group therapy with young kids, but they might use more play and things like that. Grade school children combines play, learning skills, and talk because their intellectual abilities are a little bit better. They're a little better at communicating, developing some problem-solving skills. Adolescents, they really are pretty good with identifying their emotions, modifying their responsive. They learn skills through talking and talking to other people, talking to the counselor, and they focus a lot on peer relationships and addressing specific problems. And then cognitive behavior therapy in general is trying to replace those negative self-defeating thoughts with more realistic and accurate appraisals to improve their functioning. So now we're going to talk about some actual disorders. So we have some neurodevelopmental disorders. There are communication disorders, motor disorders, specific learning disorders, intellectual developmental disorder, ASD, and ADHD. So, in case you're wondering, ASD is autism spectrum disorder, and ADHD is attention deficit hyperactivity disorder. We also can have just attention deficit disorder without the hyperactivity. So some kids do have that. Okay, so little case study. Victor, 5, will soon be starting kindergarten, and his dad, a single father, is very anxious. I have no idea how Victor is going to make it in school. He is completely out of control. I have trouble getting him to calm down. When he was little, I was kind of proud of how active he was, running from one thing to the next. I took it as a sign of curiosity and intelligence. But as he's gotten older, he's still like that, only he can't calm down and sit still for anything like other kids his age. Something has got to change. So, keeping that in mind, we'll probably get back to that eventually. Okay, motor disorders continued. So we have tic disorders too. So there are things like Tourette's disorder, which you may have heard of, persistent motor or vocal tic disorder, provisional tic disorder, and okay, I got interrupted here for a second. So anyways, we're talking about the tic disorders. So Tourette disorder is a little bit more severe than the other two. So you have multiple tics, motor tics for at least one vocal tic for more than a year. So you have both of those. Persistent motor or vocal tic, you usually have either a single or multiple motor or vocal tic, but not both. And provisional tic disorder is single or multiple motor and or vocal tics for less than a year. So sometimes things can come on kind of spontaneously and then and then go away. But Tourette's disorder really is long-lasting and can be very disruptive to a child's life. Usually, these are all going to be occurring before they're 18, and usually onset is about 4 to 6 years old. And then they peak in early adolescence, and then they kind of diminish in adulthood. So these are genetic disorder in about 90% of cases. But if you think about some of the behaviors that kids are going to be having with tic disorders, they are kind of sometimes unusual, odd behaviors. The child is going to be bullied, perhaps teased, have difficulty with their self-esteem, and have difficulties at school overall because of their behavior. Sometimes the tics can be actually very disruptive in a classroom situation. It's kind of interesting as far as comorbidities also, that along with Tourette's disorder, sometimes comorbidities might occur, such as depression, obsessive compulsive types of behaviors, and ADHD. So I have a really good example of somebody who had Tourette's disorder, and I could see the very strong OCD component. The man actually pulled out all of his teeth. So he was in his 20s, and he actually pulled out all of his teeth with a pair of pliers, because the compulsion and that urge to pull out his teeth was stronger than the pain. So in other words, it would have been more painful not to have followed through with his the compulsion. So he actually pulled out all of his teeth. So, and he also had other types of behaviors like spitting on the unit and things like that, which were, really very socially kind of unacceptable. So, and again, the depression, sometimes self-esteem can really suffer because some of their behaviors might really be quite odd and difficult for other people to deal with. So treating tic disorders, there are behavioral techniques that can be used. There are medications such as clonidine is one of the medications that might be used. They can teach kids how to reverse some of their habits and reverse some of the tics. And I have heard of other types of antipsychotic medications that sometimes can be used also to suppress the tics, but of course then it would also depend on the age of the child, because not all the antipsychotics are able to be used for kids that are under 18. So deep brain stimulation might also be a possible treatment. So in your book, they call deep brain stimulation a sort of a pacemaker for the brain. So, and of course, something like that is very intrusive is really going to be the last resort for when other types of conservative treatments have failed. So if they've tried some of the antipsychotic meds, they've tried clonidine, they've tried behavioral approaches, nothing is really working, then they may try deep brain stimulation. Okay, so now we have intellectual development disorder. So these kids have deficits in intellectual functioning, social functioning, and their daily functioning. So they have problems with reasoning, problem solving, planning, judgment, again, that abstract thinking, and academic ability. They have trouble with communication and reading social cues from other people, and behaving appropriately socially with other people, and just activities of daily living. So just think about school, home, self-care, just bathing, dressing, some of those types of things might actually be quite impaired. So assessment guidelines, we're looking for delays when we're thinking about intellectual disabilities. We're looking for possible signs of potential neglect or abuse. So sometimes kids that are delayed are very frustrating for the parent or whoever's the caregiver. So they are definitely at risk to be neglected or abused because of that frustration with trying to deal with a child who is delayed like that. So very, very important to look for those signs and symptoms. So about 10% of these kids result from problems during pregnancy or birth and include malnutrition, maternal substance abuse, so their mom has been abusing either drugs or alcohol, and perhaps even a maternal infection. Complications of pregnancy and trauma related to birth also. So we do have to think about what possible things are going on. Some diagnoses that we might have could be certainly, everything again is on that continuum. So sometimes the actual disabilities are could be either mild or actually very severe. So we do have to look at some of their signs and symptoms as far as their lack of responsiveness and their lack of cooperation. If they have behaviors like head banging, face slapping, frequent disregard for their bodily needs. So really nice table on page 181 in Varkarolus, and it just kind of goes through impaired social interactions, risk for impaired attachment, risk for injury, risk for trauma, self-mutilation perhaps, ineffective coping, stress overload. So lots of different types of diagnoses that we can think about when kids have these types of problems. And we're always going to be developing appropriate outcomes. The patient will be able to specific time-framed, measurable, and specific. Our interventions should always be that way. And the implementation, the psychosocial interventions are things that we need to think about as far as how we are going to be interacting with these kids and in what type of setting are they going to get their needs met. So sometimes kids with these intellectual disabilities can be cared for in the community, and they may be part of the public school program, such as a special ed program. And as they reach, as they get to be older, the schools are providing services to help these kids with those emotional or developmental disorders so that they can participate in school. So they're there and they are participating on a daily basis. We also have to think about hospitalization perhaps intermittently, especially if they are at risk for self-harm, if they're aggressive, or if they have really severe self-care deficits. So again, everything has to be very individualized because no two kids with these types of disabilities are going to be alike. And evaluation, of course, is are they able to meet some of those goals? Are they able to take care of themselves more appropriately, behave more appropriately, and perhaps function as a family member and as a student? Autism spectrum disorders. So ASD, I guess that's the new abbreviation. Everything's got to have initials and abbreviations and Anyways, so we have deficits in social relatedness and relationships. So these are some of the really main types of symptoms that we're looking for. They might have stereotypical repetitive speech and behavior too. So they may have obsessive focus on specific objects and over-adherence to routines or rituals, hyper or hypo-reactivity to sensory input. So extreme resistance to change, and usually appears in early adulthood. So when I used to teach lifespan several years ago, and we used to have the Denver developmental screening as part of Lifespan Clinical. So I used to get to read those, and for years I was always reading the Denvers that you guys would do on kids in the community or in your family or your neighborhood, whatever, friends had kids, and you would do the developmental screening. And most of them were very, very normal. And I do remember reading one that just made me raise my eyes with like, oh my goodness, this is a problem. So I was reading one of those, and it sounded like the child was ignoring their parents. They weren't responding when the parents would call their name. They had all these types of stereotypic, repetitive types of behavior. They could sit and watch a clock for hours. Oh dear, it was just screaming of autism spectrum. And the student actually said it was a family member's child, and she had tried to encourage that family member to bring that child in for an evaluation, but they were in denial and really did not want to do that. So yeah, so that was one of the most interesting Denvers that I ever read. But we do have to look at their just inability to relate to other people. They may be unyielding to cuddling. They may not look at you with eye contact. Don't relate to other people. Really have trouble with communicating and socializing. They may be focusing on things that are like mechanical in nature, and they're just like fascinated. They can watch something for hours. They may do a whole lot of other types of spinning, twirling, flapping, those types of behaviors. And again, everything it's a spectrum, so there might be some people that are very, very impaired, and they're on the lower end of that continuum. And you also have some very high functioning autistic people that actually are much more capable of living happily in the world and being productive, although most of the time there is some aspect of relationship that still might be difficult for them. So I am going to put another video out there for you if you care to watch it. It's really quite interesting, and I don't know if you've ever heard of Temple Grandin, but she is somebody who has a PhD. She is a professor, and she actually is extremely very, very bright, very talented, but of course had difficulties socially throughout her whole life related to her autistic disorder. So she is really quite an interesting person, and somebody that has become quite successful in spite of her disability. So that hyper or hyporeactivity to sensory input, so the world can be crashing around them, and they may be just sitting there ignoring it all, or sometimes they may just be extremely sensitive to any kind of stimulation, and they lose control, they start screaming, they put their hands on their ears. So we do have to watch for all those types of behaviors. And that extreme resistance to change. Boy, they really like a routine. It is so important to try to get these kids to have a routine. So I have a student who told me that they have a child who, some years ago, had a child with autism, and they would go grocery shopping every week, and she would bring the child, and to try to get the child to behave for the time frame of the shopping trip, the mom would always promise at the end of the shopping trip, we'll go to the bakery section and you can pick out your favorite cookie. So apparently the favorite cookie was a sugar cookie with M&Ms. So every week it worked. Child would maintain control. They'd go to the bakery department. The child would get a cookie. So same thing happened one week, and at the end of the shopping trip, they went to the bakery department. They were all out of that particular type of cookie. So, of course, the child had a meltdown. So, just to show you even something little, they're not able to flexibly say, oh, they don't have that kind, I'll take the chocolate chip instead. They really can't do that. So, usually, the appearing in early childhood, we're kind of thinking about usually before 3 years old, you're going to be noticing some changes in the child. So again, if you look in your book on page 182, there's some nice orange tables that talk about assessment guidelines and the DSM criteria for autistic disorders. So we have to maintain that nursing process when we're looking at these kids. So we have to make our assessments, and we're looking for uneven delay development and kind of lags in their development or loss of acquired skills. And so sometimes they even suggest that using a baby book, a diary, or like videotapes of the child from various family members and caregivers can be very helpful to aid in that diagnosis. So looking at the child's communication skills, verbal and nonverbal, social behaviors, any aggressiveness or self-injurious behaviors, assessing the parent-child relationship to see if there's any bonding. So it may not really be apparent that there's any bonding going on if that child is really unable to emotionally, attach to the parents. We also, again, always have to think about the possibility of abuse, because these kids they're frustrating to work with sometimes because they're not listening to you, they're not responding the way that you would like them to respond, and so they are very high risk for being abused. So we have to think about diagnosis, and we have to think about our nursing diagnoses that we're using, so certainly risk for harm, and we have to think about with some of those behaviors that we're thinking about, head banging, and we have to think about impaired communication because of that inability to bond and to communicate, impaired social interaction, and certainly any of the diagnoses that can relate to the family. Also, we have to think about perhaps the diagnosis for the parents in terms of their inability to be a really effective, good caregiver. So caregiver role strain might be a really appropriate diagnosis for the parents. And identify your goals, the implementation, certainly is psychosocial intervention, psychobiological, and of course the most important intervention really truly is identifying the problem with the parents, getting the parents to accept help, and usually if the child is enrolled in some type of an early intervention program, and they work with those children very, very carefully, and they work with those children for a good couple of years. I have a friend who has a child with autism, and that child has actually done pretty well over the last few years and is now in school because they had this person, I believe it's an occupational therapist, come to their house, and I believe it's like 2 or 3 times a week, and for hours at a time, very, very intensive work with that child. Those types of programs are extremely helpful. And then after the interventions, we certainly want to do an evaluation and see where they're at. Are they meeting the goals? Are they able to function more appropriately and communicate more effectively? So, attention deficit hyperactivity disorder. So you've probably heard of ADHD. You may know some people that have it. There's a lot of controversy with ADHD. There are some people that just don't believe that it's really a diagnosis, that it's more of a social problem, and that it's a behavior problem, that if kids would just be more disciplined in school, or perhaps their family should be more disciplined. So it's kind of seen as that type of an issue rather than a medical problem by many people. And then I read an article about why French children don't get ADHD. And of course that again just kind of further reinforces that it's a behavioral problem that can be easily fixed. And I'm not really sure that that's actually accurate. But this article was very interesting because it talked about the difference in our culture in America and French culture. And that in France, children would be, from very early on, they would be given more structure than American children would, especially when it comes to waiting to get their needs met. So, a baby in French culture would not be given the bottle whenever they're hungry. They would schedule a feeding for a certain amount of time, and the baby would cry because they were hungry, but they would wait for the scheduled time to feed their baby. So, Again, I don't know if this is accurate for every French household, but this is basically what the article said. And then as the child is getting older, they don't just feed their children snacks whenever they're hungry. They make their child wait until the next meal. So if they're hungry after breakfast, maybe it's 11 o'clock in the morning and they're hungry, they're not just given a snack. They're told lunch is in an hour, wait for an hour. And then the children learn kind of like discipline and self-control. So that's their premise as to why there is a less degree of ADHD in France. So I thought that was kind of interesting, but, of course there's always more to the situation than we think sometimes. So, but, you will hear schools of thought out there that people just don't think it's a real diagnosis. So the symptoms that we're looking for are an inappropriate degree of attention. So they're not able to pay attention very much. They're impulsive with their behavior. So impulsive just really means that there's not very much time between the thought and the action. So they just kind of go right to the action and very little thinking about what they're doing or the consequences of what their actions are. They're hyperactive, they're on the go, they're moving, they're talking constantly, they're busy, they're fidgeting, they're up and down. Have a hard time sitting in school and doing like a worksheet. That would be torture perhaps to somebody with attention deficit disorder. They also have they're very talkative. We have to look at their social skills. Sometimes they're not able to really socialize and interact very appropriately with their peers. So they sometimes suffer. Their social skills aren't very good and they're suffering with their peer relationships. They maybe don't have too many friends. They're certainly not the popular kids. So that might be very kind of distressing to them. They may suffer academically also because they're not able to focus. They're perhaps very bright, but they can't focus enough to learn the material. So lots of comorbidities with attention deficit. Think about the child who is an adolescent and is suffering from this huge comorbidity of substance abuse. So these kids are very, very high risk to be using drugs and alcohol, even as a young teenager. So that's something we really have to take very, very seriously. Other types of comorbidities that happen with ADHD is certainly it impacts a child's self-esteem, because they're maybe not doing very well in school because of their inability to pay attention and stay focused. Their grades are failing, so then they may feel that they're stupid. They can't, they don't feel that they're very bright or talented, and perhaps they really are. So their self-esteem is really going to suffer. Again, their peer relationships, so depression, anxiety, and substance abuse are actually huge comorbidities. Other comorbidities that you might have along with ADHD could be conduct disorder, which we'll talk about soon, disruptive mood dysregulation disorder, and specific learning disorders. So diagnosis, children and adolescents can be overactive. They may display disruptive behaviors that are impulsive, angry, aggressive, and sometimes dangerous. So they have a hard time maintaining their attention in situations that require attention. So even think about things like as adolescents get older and start learning to drive. So just think about how much attention that you have to, maintain in order to drive a car. So they have difficulties with family relationships, peer relationships. They're in conflict with other people. They may not follow age-appropriate social norms. So again, lots of different diagnoses that we can think about for kids with ADHD also. And again, we're going to be looking at our outcomes and always evaluate those. So, little case study again. Victor has started kindergarten and still exhibits the same problems his father expressed frustration with earlier. His hyperactivity in particular and his inability to listen when his dad tries to correct him or slow him down. Victor is assessed today for the following: level of physical activity, attention span, talkativeness, social skills, and comorbidities. So we need to think about some interventions. So what do we do when kids have ADHD? So some psychosocial types of interventions really focus on getting these kids to get better coping mechanisms. So it's really not helpful if they're blaming other people or if they're not taking responsibility for their actions. And, that can be a problem for adolescents in general. But just getting them to really get some better adaptive coping mechanisms. If kids are acute danger to themselves or others, they're going to be in the hospital. But honestly, most of the time, it's kind of unusual to see somebody just come to the hospital for ADHD. There would usually be another comorbidity occurring at the same time, depression, anxiety, or substance abuse types of issues. So therapy can really kind of help them to gain some better internal control so that they can control their behavior a little bit more. And if family is involved in the therapy, it actually helps a lot. It helps the child, gives them a lot of support, and then the parents can develop skills to provide the nurturing and set consistent limits for those kids, because it really is very helpful for them to do that. And then also it's very helpful for the teacher to also work in conjunction with the parents to kind of come up with a game plan for how to deal with that child and how to help them with their behaviors. So there are medications, so psychobiological interventions, so psychopharmacology. We do use medications for kids that have ADHD. So we have to think about Ritalin as kind of the main medication that we use, but there are other meds that come from that same classification that also might be used. So we have to think about the fact that some of the medications, the stimulants, such as the amphetamines, dextroamphetamine, Vyvanse, I'm not going to even try to say that word right now, I'm really too tired, Concerta, which is like a long-acting Ritalin. So many of those medications are considered stimulants, and usually they're under age 6, they are not recommended. And there are some long-acting and some shorter-acting medications in that classification. So either, once a day or twice a day. So we do have to think that most of these medications that are given for ADHD are considered stimulants. However, they have the exact opposite effect in the brain of the child with ADHD, and they actually work to calm the child down and to help them focus. But it still is, being that it still is a stimulant, it still may affect their sleep and their appetite. So those are two really big things to watch out for. So if the sleep is disrupted, it's often advised just to really try to make sure that child gets an appropriate amount of exercise during the day so that they truly are tired. Try to schedule the dose. If it's like a twice a day dosing, try not to give that second dose any later than 3 or 4 in the afternoon, so that the child can settle down and get to sleep. But many times that the once a day dosing, the 24-hour long-acting Concerta, can be helpful if it's given like first thing in the morning, and then most of it has worn off by the time the child is going to sleep. We really do have to think about their appetites also, because these medications do suppress the appetite. The kid just doesn't feel hungry at all, and they may be suffering from weight loss. So we really have to make sure that they get adequate nutrition, and they may need some extra calories even. Milkshakes and things like that can be real helpful to get them some extra calories. There are a couple of medications that are non-stimulants. So I'm looking at page 187 in Varkarolus. There's a nice table of FDA-approved drugs for ADHD. So atomoxetine, clonidine, and guanfacine are 3 medications that are not stimulants. So the Strattera or atomoxetine is actually chemically related to the antidepressants. So that can be very helpful, and it's not a stimulant, and it's also not addicting. Of course, the stimulants are going to be addicting, so there's also a high potential for abuse. So sometimes kids sell the medications to other kids, they give them to other kids, so they're sold on the street. There's street value for Ritalin and some of the other ones, so we have to be really, very careful about those types of medications. But with the non-stimulants, there isn't that risk. Clonidine is a blood pressure medication that is also used for opiate withdrawal, and it does somewhat help with ADHD. And the Intuniv also is another medication that is, I haven't seen it used a lot, but it can also be used for ADHD, and it is, again, not a stimulant. So we always have to look at, as far as the evaluation, is the child's school performance improved? Are they having better peer relationships? How are they functioning as a family member? Do they have less impulsive behaviors, less harmful behaviors? So lots of different things for us to think about when we're evaluating the medications and the effect of the meds and the effect of the treatment overall. One other concept I just want to talk about quick too is the idea of a drug holiday. So you might have heard that term before, and basically what that means is a period of time where the child would not be taking the medications, just to kind of give them a break. So summer is usually considered a good time to take a drug holiday, so the parents perhaps can take their child off the medication for the summer and start them back on it maybe a week or two before school starts. So just to kind of give them a break and lets them maybe gain some weight back and get their appetite back a little bit. But if the child has some structured summer activities, like if they're going away to a camp for a week, perhaps they want to be on that medication during the time that they're at camp, just so that they can function a little bit more appropriately. So, Victor is diagnosed with ADHD after being assessed both at home and at school. To begin with, a psychiatric mental health nurse works with Victor to help him change his behavior pattern of misconduct, working with Victor's father as well to help him develop internal controls and help them both improve coping and support. So Victor expresses delight over a few cognitive behavior therapy games aimed at developing problem-solving skills and conflict resolution. So use of medications are discussed as a possibility. So again, we're hoping that as an outcome that when we evaluate, we're going to see that he's got less hyperactive behavior, more engaging social relationships, activities of daily living going well, school performance going well. So we definitely need to gather data from the family and school situation to kind of make a good evaluation of how things are working. So another audience response question: which statement demonstrates that Victor's dad understands the diagnosis of ADHD? Victor will never be able to graduate or go to college, but may be able to learn a vocational skill. Victor's performance will improve in a structured setting that provides rewards for appropriate behavior. Nothing is wrong with Victor. The school hasn't provided qualified teachers in classroom settings. Victor is just going through a stage. This problem will go away with time. So I'm hoping that you picked B, that his performance will improve, and that sometimes that reward system, different types of working with kids in all the types of therapies, and perhaps Victor maybe is a little bit young. Perhaps if he's under 6 years old, most of the medications are not recommended. They're just not indicated for kids younger than 6. So perhaps medication could be explored in the future, but they may want to just try conservatively and see if family therapy and individual therapy can be very helpful for this child. So the Center for Quality Assessment and Improvement in Mental Health Measures. So this is has to do with a quality improvement method, and it is we want to think about access to child specialty care for treatment of depression. And because depression is a comorbidity, family involvement in the treatment of ADHD. Stimulant medication treatment certainly is it's an evidence-based approach for treatment. Antipsychotic treatment for childhood psychoses, completion of treatment for substance use disorders, and referral to post-detox treatment services. So again, we really do have to think about that these kids, there's so many comorbidities, and that substance abuse is definitely one of those that we have to really assess for very carefully. So there are actually very specific assessment tools that you would use for this quality improvement measure. So, all right, so we really need, I think that's the same, yeah, that's the same slide as we just had previously. Okay, I'm not going to talk about that again. Audience response question. Which child would be most difficult to diagnose for a neurodevelopmental disorder? 3, 5, 8, or 12. So I'm hoping you picked 3 because a 3-year-old has less ability to communicate. They have not, their brain is really very underdeveloped in terms of their ability to respond appropriately, to behave, to their thought processes are not very far along, so they don't have that ability to abstract, to think abstractly. And just emotionally, they're not able to control themselves very well. They're still working on self-control, but they really they're very impulsive and very emotional, and they don't, sometimes having tantrums, so they don't always respond to verbally what you want them to do. So very, very difficult to diagnose that developmental disorder. You always hope that it's a phase they're going through. They're just a child. Their brain is still developing. So much easier to diagnose a child who is able to communicate with you, and that you can actually assess their behavior a little bit more. They're more verbal. They're able to just communicate effectively with you. Another audience response question. A 4-year-old frequently lashes out in anger at adults and other children. This child's style of behavior is an aspect of, so I'm hoping neurobiology, temperament, resilience, or culture. Hoping you picked B, that this would be an example of the child's temperament. So for whatever reason, this child is highly more emotionally reactive. So if they get angry easily, that is an aspect of their personality. So that is their temperament. Chapter 21. So now we're going to be talking about a few impulse control disorders, and then we'll be done with this learning plan. So Jeff, 15, is described by his parents as rebellious to the point he's really impossible to control. No matter what we try, he's been like this from the time he was very small. We're at our wits' end. In fact, Jeff's parents are not the only ones concerned. His history shows that from the beginning in kindergarten, teachers and authorities have documented him as spiteful, vindictive, and physically aggressive. So that is something that is a little bit above and beyond, kids that might just have difficult personalities. So we have to think about a couple of different medical diagnoses. So the first one we're going to take a look at is oppositional defiant disorder. And so, of course, this has some an abbreviation. It goes by ODD. So OCD, ODD, anyways, we have too many initials. So oppositional defiant disorder. Now, these kids are difficult. However, I want you to listen very carefully and really understand the difference between oppositional defiant disorder and kids that have conduct disorder, because there really is a huge difference between the two. So oppositional defiant disorder, they have angry and irritable mood, they're defiant, vindictive behavior, they have social difficulties, conflict with authority figures, especially parents and teachers. So they're going to have some academic problems. in relationship to that. So they really are kind of difficult. They have trouble with their peers also, because they might also be kind of very know-it-all with their peers, or just constantly putting their peers down, and just having kind of social difficulties. So maybe you're even thinking, if some kids have, especially teenagers, think about sometimes having an angry or irritable mood. They're kind of defiant, so they don't want to do what you tell them to do. They may want to get back at people, especially like their siblings, their brother or their sister. You might think, that's kind of like almost normal adolescent behavior sometimes. And sometimes it is, but that's the point. If this is a persistent, enduring pattern of behavior, then it becomes a problem. It's just not that they're occasionally like argumentative and irritable and, like teenagers kind of are, but it really makes it extremely difficult for them to be successful at school, to have friends, to be a functioning member of their family. So that's really when it does become a problem. We have to think about risk factors. So there might be some genetic component. Usually if you have a family history of mental illness, a child is more likely to develop this. There are actually a lot of different brain changes that are happening. So if you think about the numerous neurobiological causes, there's difficulties in the brain structure and functioning, and that has to do with just those higher order parts of the brain where the person is able to control their behavior, tolerate frustration, things like that. So we're thinking about that whole aspect of being impulsive. So definitely a comorbidity again would be that ADHD with oppositional defiant disorder. Some kids with this just kind of get better over time, even without treatment. But for some, it can actually turn into some other difficult adulthood behavior problems. So it is definitely better if a child has oppositional defiant disorder that they do get some treatment. The family dysfunction can definitely also play a role. So we always have to look at the environment that the child is in. Do they have adequate parenting? Do they have problems with attachment? So they have children from larger and impoverished families are kind of at risk for this disorder. So if they have an insecure attachment to that maternal figure, so they weren't really able to attach to their mom very well. So lots of different things to think about. So we have to think about treatment approaches. So our psychosocial interventions, we really need to work with the needs of the child and the family. The child, we want them to be able to help them to manage their anger and improve problem-solving ability, and kind of thinking about ways to decrease that impulsivity and to be able to socialize with other kids in a little bit better way. And psychobiological interventions, so there really isn't a medication specific for the treatment of oppositional defiant. However, if they had excessive amounts of anger and aggression, so you may just be targeting symptoms, and Depakote might be something that might be able to help them in reducing that aggression and irritability. So, but otherwise there really isn't anything specific for this type of disorder. Getting back to the case study, Jeff, who's diagnosed with oppositional defiant disorder, is taken to the principal's office after assaulting and injuring another student. Which comment is this adolescent most likely to make? So, I lost my temper, but it will not happen again. I'm sorry, I'm embarrassed that this happened. I failed my math test, and I guess I was just having a bad day. And so what if that kid was hurt? I should have beaten him more. So with oppositional defiant disorder, they're not going to be completely without remorse like you would see in an antisocial personality disorder or like a psychopath personality disorder. So C would be the best answer. So, I failed my math test, and I guess I was having a bad day. So they kind of rationalize their behavior and they put some blame on something other than themselves. But D, it would really not be D. D is going to be for conduct disorder. So again, really want you to know the difference between oppositional defiant and conduct disorder. So in conduct disorder, we haven't talked about it yet, probably the next slide. That's kind of like a precursor to that antisocial personality disorder. The people that scam and con other people, they could kill somebody if it gets their needs met and they don't really care. There's no remorse. So really in oppositional defiant, they do have remorse. But in conduct disorder, they don't have remorse. So that would really be what D is, while C would be the child with an oppositional defiant disorder. We also have something called intermittent explosive disorder, and that's an inability to control their aggressive impulses. And you can see this diagnosis in adults. So even I think in your book it says up to about age 50, you can see intermittent explosive disorder. So they do have some remorse, so they probably feel bad about what they did, but they may tend to rationalize it and say, well, I did it because of whatever. But it really makes it very, very difficult for them to maintain interpersonal relationships. So if you just all of a sudden explode about something, you end up in a rage, and could be just triggered by something like somebody driving too slow in front of you, or the book talks about a couple of different examples, but you're having problems with your relationships with other people, perhaps even on the job. If you're not able to control your impulses and your anger in a job situation, you're probably not going to last very long, and you may even end up having criminal difficulties and getting in trouble with the law because you explode, and you may do something that you actually will regret, and that is against the law. So they really do have some great deals of difficulty with living and with working and being with other people. So comorbidities, depression, anxiety, and again, substance use disorders are very highly prevalent because many times, again, people are trying to self-medicate and trying to calm themselves down. There's also comorbidities of antisocial and borderline personality disorders. So that whole aspect of being impulsive and having, engaging in behaviors that are self-destructive or destructive towards other people. So risk factors, again, some neurobiological abnormalities and conduct or violence in the family of origin. Or conflict or violence in that family of origin. So the child is learning as they're growing up, they're learning that violence is the way to communicate and to manage conflict. So treatment would be a combination of therapy and possibly medication. So usually those two things work quite well together. So some of the medications that might be used might be some of the antidepressants, Prozac, Paxil, so other SSRIs. Lexapro might be very helpful in some of those, some of these people with these diagnoses. And sometimes even an antipsychotic can just have a calming effect, especially if they really have, quite a bit of anger and rage when they experience an episode. So that can really be very, very calming for that person. But again, we have to look at the age and make sure that they're an appropriate age for that. So now conduct disorder. So this is the one that's really very, very serious in terms of a childhood illness. And if a child has conduct disorder and is not treated, then this child is very likely to grow up and to be a person who has an antisocial personality disorder. So if you remember when we talked about that in Learning Plan, I think it was Learning Plan 4, that those are the people that take advantage of other people, they use other people, they're trying to get their needs met, and they literally don't care if they kill somebody as long as they get their needs met. So that lack of remorse, they don't really care what they did. So again, this is the childhood version of that disorder, and again, left unchecked, it will be that the child will become antisocial. So the behavior is usually abnormally aggressive. The rights of other people are violated. So in intermittent explosive disorder, the rights of somebody may or may not be, they may not be infringing on somebody's rights. And certainly with an intermittent, an oppositional defiant disorder, usually the person's rights, another person's rights, are not being violated. But they are being violated, and they're actually having behavior that we could really say is downright criminal when they have conduct disorder. So they disregard norms of society, rules are disregarded, and they absolutely have a lack of remorse. So they use the defense mechanism of rationalization pretty often. They always have an excuse for why they did something, and it has nothing to do with, feeling badly about it. So complications of this disorder, they definitely have academic failure, school suspensions, dropouts. They're going to end up in juvenile delinquency. They're just going to end up in the juvenile court system, drug and alcohol abuse, and again, that many times their behavior is just downright criminal. They also can have problems with pyromania, so setting fires, and kleptomania, stealing objects. So treatment approaches, for sure, they need psychosocial interventions, and they really do need that early, because if they don't get that treatment, they really are very likely to end up as having an adult antisocial personality. And again, many of those people do end up in the jail system if they do get caught. So very similar as far as the type of therapy that you give to a child with a conduct disorder. So you're working on reducing their aggressive behaviors, trying to get them so that they're not quite so disruptive. Medications might be helpful to decrease the intensity of their outbursts and may help them to, if they're having depression, anxiety along with that, to kind of feel a little bit better. And some of the medications, again, the antipsychotic medications like Abilify, Risperdal, can help reduce some of that anger and aggressiveness. So we need really to do a very good assessment of suicide risk. So they are at risk really for violence directed towards other people and violence toward themselves. So they really are a high suicide risk. There are some specific assessment tools that might be used in the schools or in the doctor's office. The self-assessment, again, always deals with how do we feel about this kid? Are we angry at this kid? Are we frustrated? Are we blaming them for their own lack of ability to control their impulses and their behavior? Are we blaming the family? So very important to kind of work on our own feelings when we're dealing with kids. There's actually a very nice table on page 400. So yeah, we're in chapter 21 that looks at different, kind of like a checklist of different behaviors with oppositional defiant and conduct disorder, and things that you could check off, like argues with adults, loses their temper, is angry or bitter, destroys things. I mean, it just kind of goes through the two. So really good it would be really helpful probably to look at that table. And again, especially to be able to differentiate between the oppositional defiant and the conduct disorder. So we always need to be looking at our nursing diagnoses and our outcomes. So we have to think about I do have the table outlined, and that is on the next page. It's on page 401. So we're thinking about the diagnoses of risk for suicide, risk for other directed violence, defensive coping, impaired parenting, and that would be something that you would diagnose the parent with. That is very possible something else is also going on. So we have to look at the goals, that we want the child to express their feelings appropriately. We want them to refrain from suicidal behavior, plan for the future, communicate effectively, cope effectively, things like that. So again, common nursing diagnoses that I just talked about. Self-assessment, a common belief is that the patient is choosing not to get better and that concerns for safety may be exaggerated. So we do have to think about our own negative attitudes that might get in the way of appropriate care. So we have to be really careful about controlling our attitudes, because sometimes if we have an attitude, it kind of shows. It may show in the tone of voice that we have, the words that we choose when we talk to people. So if we really think that that child is purposely doing this, that they don't want to get better, we really have to, talk to somebody, get some supervision, and get a better way of thinking about this person and this illness, that they need some help, certainly, but that it is not that they're controlling it and they're purposely engaging in some of these really difficult behaviors. So the nurse's ethical and professional responsibility is to provide equal care to all people. And again, this might be kind of hard sometimes. It might really challenge you. So you may even get into some situations in clinical where it's really difficult to care for somebody appropriately. So those would all be things that you would be talking about to your peers, your supervisors, and we certainly can talk about those in post-conference if anything like that comes up. So we really need to be empathetic and put ourselves in their shoes and try to at least take that walk with that person in their misery, and consider the patient's environment of origin and the history of constant negative responses that they have had to deal with. So it can help you to maybe perhaps feel a little bit more, feel more empathy towards that person. You don't want to feel sympathy, you don't want to feel sorry for them, but certainly empathy allows us to at least recognize where they've come from, the trauma that they've been through, and that they are a person who is worthy of your professional care. So the implementation then, again, psychosocial interventions, pharmacological, health teaching, and health promotion are all very important. Teamwork and safety, especially if a child is on an inpatient unit, for sure we all need to be working together to make sure that child is safe, and if they are have feelings of self-harm towards other people, we need to make sure that everyone else in the environment is safe. Again, seclusion and restraint, we don't want to use those types of interventions unless it is absolutely necessary. It is the only way to help to control that person's behavior so that they don't hurt themselves or hurt anyone else. But we're thinking about evaluating kids with these types of impulse control disorders overall when we're evaluating if the interventions were helpful or not. We really do need to think about, is the child, are they safe? Are they able to stop the blaming other people and denial of the responsibility in anything? And are they able to cope in a little bit more mature and adaptive way? Are they able to make goals for themselves? And are they responding to things like setting limits and behavioral expectations? Are they responding to that structure and the boundaries that are set for them? And are they engaging in more age-appropriate activities? Are they achieving their goals both at school and at home? So again, lots of things to think about. These kids really can be very difficult. Again, conduct disorder, much more serious than oppositional defiant disorder, even though there's definitely some overlap in the way that these two disorders are treated. So that is the end of Learning Plan 6.